Should we start?
I feel we can start, madam, if you have, we have your permission.
You please.
Udupa sir, can we start?
Yes, sir.
Okay. So, good afternoon, all the pharmacology friends, and welcome to this platform of National Association of Pharmacology and Therapeutics. Today is the third session of
Yes,
this
sir. We
series.
start.
Today is the third session of this competency-based medical education in pharmacology series, and there are two moderators and two speakers today. I would be pleased to introduce the moderators for today's session. So the first moderator for today's session is Dr. Sanjib Das. He's MD Pharmacology Fellowship in Diabetes, Postgraduate Diploma in Hospital Administration, Advanced course in the Medical Education. He is presently working as a professor and head Department of Pharmacology, Government Medical College, Ratlam, Madhya Pradesh. He is having 23 years of postgraduate teaching experience of pharmacology, biomedical research, and foundation of the clinical medicine course in India and abroad. We are fortunate to have that he is having a wide range of experiences of working abroad, out of the country also, where he has worked as a chair and basic science program in various international universities, imparting NBME, USMLE style teaching both the Caribbean and USA countries. He has worked as a consultant with the International Medical School preparing for the CHAMP and ACCM accreditation. Currently, he is a co-chair of Scientific Committee of GMC Ratlam and working as a coordinator of the Medical Education Unit and Curriculum Committee, GMC Ratlam, Dr. Sanjib Das. And the second moderator for today's session is Dr. Sandhya Kamat. She is a professor and head Department of Pharmacology and Therapeutics, very reputed institution of the country, State GS Medical College and KEM Hospital, Mumbai. She is having undergraduate experience of the 30 years and postgraduate teaching experience of the 22 years. She is members of various institutional ethics committee, chairperson of the institutional animal ethics committee. She is the treasurer, forum for ethical review committees in India, FARCI, popularly known, and nodal officer of the GSMC multidisciplinary research unit. She is faculty at workshop on clinical research methodology, GCP preclinical research, and the herbal research. She has won 15 awards for oral papers and posters at various national and international conferences related to use of the rational use of the drugs, ethics in research, drug utilization studies, and evaluation of the medicinal plant in the treatment of various disorders. She is also a co-author of the popular book, Pharmacology and Pharmacotherapeutics, Dr. Sandhya Kamat. So with these introductions, I would like to hand over the session to the first moderator of today, Dr. Sanjib Das.
Am I audible?
Yeah, you are audible, sir.
Okay. So thank you, Dr. Kamal, for a elaborative introduction of mine. Well, let me start off this session with a warm welcome to all the participants and resource faculty. Today's session is micro OSCE for assessment in pharmacology. Why OSCE is important? Probably OSCE is the most valid and most reliable method to assess skills. When I say skills, global skills that might be coming from cognitive domain or psychomotor domain, or soft skills, which are classified under affective domain, which includes professionalism, interpersonal relationship, communication, ethics, and many other generic skills an undergraduate needs to hone up before they start interacting with the patient and also the community. Now, if I am to analogize this CBME program, entire CBME program with Taj Mahal of India, our antique pride, probably if I am to analogize the various elements of CBME with the pillars of Taj Mahal, then probably assessment would be the strongest pillar that gives maximum strength to this Taj Mahal, and probably that OSCE would be the strongest iron framework that gives maximum integrity and strength to these pillars. So probably that's why NMC then necessitates or strongly recommend the inclusion of OSCE in undergraduate and postgraduate competency-based medical education curriculum. Now, having said that, this designing and implementing OSCE would be very daunting in terms of we need to have detailed blueprinting on diverse areas. It could be the defining the objectives or the station development or case development, standardization or recruitment of trainee examiners or standardized patients, logistics, piloting, grading rubrics, or data collection or data analysis and giving feedback. So that's why, moreover, actually, from criticality versus feasibility standpoint of view, we, the different colleges across India, we are on different page. And probably that's why there is a need for modified OSCE. And that modified OSCE, which is also called micro OSCE, which is easy to design, easy to implement, monitor, and also evaluate. And that's why today's session is all about introducing this micro OSCE in pharmacology. So Dr. We are going to welcome Dr. Sushil Sharma sir as a speaker for this session. Sir, currently you are holding the post of Professor and Head in the Department of Pharmacology, All India Institute of Medical Sciences, Mangalgiri. You have academic knowledge and accomplishments in diverse areas. And some of the important one that I am going, which is popping up in the slides, I'm going to read those aloud. You are working as an Associate Dean of Research and MEO Coordinator. You served for 24 years in the Indian Army, has been a teaching faculty at ACMS, New Delhi, and AFMC. You have completed advanced course in medical education from MCI, Nodal Center, GSMC, Mumbai. You are a resource faculty at MCI Regional Center at AFMC Pune. You are also MCI observer for the RBCW workshops. You published a book titled Drug Autobiographies in Pharmacology. You edited for RX Specters, the official newsletter of the National Association of Pharmacology and Therapeutics. And you also remained as a reviewer for various journals. Now, we deeply acknowledge your academic achievements and accomplishments. And we trust that by the end of this session, we, all the audience, will get a comprehensive grasp on the micro OSCE, and also that will to help us to implement it at our institution in a customized way, right? So, Dr. Sushil Sharma sir, this platform is yours now. You can start when you are ready.
Thank you, sir. Thank you very much. Am I audible, please?
Yes, you are.
Yeah, can I just get permission to share my slides, please? Am my slides visible?
We can see your desktop, sir. Yeah, slides are, yeah.
What
coming.
about?
Yeah, now we can see.
Yeah. Thank you, sir. Thank you very much for the introduction. And without much ado, I will just dwell into the topic. Some echo is coming. I don't know. Is my voice audible to everyone, sir? Kamal, sir?
Yes, sir, you are audible, quite audible. Thank you.
Okay. As we all know, assessment is something which drives student learning. If the students have to learn, they need to be assessed properly. Having said that, medical teachers have always been concerned about the assessment. Assessing students is not very easy. The assessment method has to be valid, reliable, feasible, and acceptable. And having an assessment method which actually fulfills all these criteria is a very, very daunting task. And that is the reason it's very important that we put our mind to assessment and try to use the best assessment that is possible. If you look at the Miller's pyramid, it actually shows the various assessment aspects which need to be checked. And if you can see from this image, you have the cognitive domain and the skills domain. The cognitive domain, the knows and knows how, is not very difficult to assess. We have lots of methods by which we can assess the knows and knows how. Maybe it's long question or MCQs and various other things. But the problem comes when you want to assess the shows how and does. And for the purpose of UG students, we can confine ourselves to the shows how, where they are actually, we are assessing their skills in a simulated environment. So what happens is, what is important for us is to see how we can assess the shows how component of the Miller's pyramid. Yeah, this is a snapshot of what are the various assessment methods which we can use for various aspects of Miller's pyramid. And as you can see, the knows and knows how component we are all doing all the time, whether it's MCQs or essay questions or short notes, we can easily do that. But when it comes to the shows how, this is where the OSCEs actually come, and we have to use OSCE for assessment of this shows how component, because they cannot be assessed properly by the traditional assessment techniques. A word about the history of OSCE here. When the time came for the students to be assessed, traditionally we had a long case where the students were given a case and they were supposed to take the history, examination, and various other things, and then the case was presented to the examiner. But there was a lot of problems with this long case, because different students got different cases, and if the cases were also same, the patients were different. Some patients were more cooperative, some patients were less cooperative, and examiners were different. Certain examiners were taking 10 minutes, certain examiners were taking 20 minutes. The kinds of questions that were asked, they were totally different. So in suffice to say, there was no structure in the long case, lot of subjectivity, lot of bias, and reliability was very poor. And that was when people started thinking about something better. And the OSCE actually came, which actually sees that you have the same patients, same problems, and same examiner standards. And the only thing different is the students. So what, as you can see from the image here, the first traditional long case had 3 variables, while in OSCE you have reduced the number of variables and now you just got 1 variable. So it's much more objective. So that is where the long case got shifted into the OSCE. OSCE, I'm sure we are all aware that it is nothing but a circuit of stations. And these stations are usually connected in series. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That's how the OSCE stations actually move. And when you talk about OSCE station, each station is devoted to assessment of one competency, which the student is supposed to perform, a specific task at each station. And once the student has finished with one station, he rotates to the second station, goes to the third station, and this is how he keeps on performing the task at each station. And they move from one station to another in the same sequence. This is very, very important in the traditional OSCE. everyone moves in the same fashion here, and the performance of the students is assessed independently at each station by the same or an equivalent examiner using a standardized checklist. So this is what is the traditional OSCE. Now, as we have seen, the OSCE is a hallmark of chain of stations. And when you talk about stations, you could have the procedure stations where the student is supposed to carry out a task. And that task is actually observed by an examiner. And how does he mark? He has got a proper checklist. What are the ways to mark? And each component has got a specific number of marks. And he sees the student performing the task and he marks it then and there. And usually the examiner does not interact with the students. The students come, do the activity, the examiner just marks it and the students goes off. Certain procedure stations typically are called critical stations, which when I say critical, it is actually checking something which is really very important. And many times it is said that you have to pass the critical station to actually pass the entire OSCE. So that is also one aspect which I thought I'll just highlight here. The second type of station could be a question station. Unlike the procedure stations where the student is doing something and is being observed by the examiner, in question station, it is unobserved. There is no examiner there. And the student, when he reaches the station, he has got a case history. He could have a question. He could have a simulated problem. He could have some data which he needs to interpret. So there is some question there and the student has to work independently and give the answer. So here in the question station, there is no observer and these answers are actually marked. The marks are given later on by comparing it with a key. So that is in question station. While every 30 or 40 minutes into the OSCE, you have a rest station where the student can be given 2 minutes rest before he goes to the next OSCE. Now, this is what I just mentioned here: procedure station, question station, procedure, question. So that's how the student moves from one station to the another. Now, can we use OSCE in pharmacology? As we all aware, practical assessment in pharmacology is a very, very challenging task because, there are, and especially with the pharmacy component going away, you have to actually think as to what skills you're going to measure and how are you going to measure. So that is something which you have to see. And if you have to use OSCE actually in pharmacology, you need at least a classical OSCE needs 16 to 20 stations. And each station needs 10 to 15 minutes. And sometimes you have to have real patients with diseases. And more importantly, the number of students should be equal to the number of stations. So if you have 25 students having practical in one day, you need to have 25 stations. So if you see here, it's very, very resource intensive. A lot of infrastructure is required, a lot of manpower is required. So sometimes it may be difficult to have a classical OSCE as a examination model in pharmacology. So what is the alternative? We could have something called micro OSCE. Micro OSCE term is something which is little uncommon, but micro OSCE is nothing but you are having just about 4 to 5 stations and where you are checking important skills of the patients, of the students. You may not have real patients at any station. You may just have simulated patient. Time given is also just about 4 to 5 minutes. So suffice to say that it's a truncated and reduced form of OSCE, just like we have micro teaching in place of a traditional 1 hour lecture. Similarly, micro OSCE is something which is little more feasible and can be employed in place of a full-fledged OSCE. One term I thought I will just highlight here because certain questions actually come many times. What is OSCE and what is OSCE? Traditionally, there was a thought process earlier that for phase 1 and phase 2 specialties, where the students are doing some practical examination and there are no actually patients, you can call it objective structured practical examination. But today that is no longer the case. Even if the student is doing a procedure which is not involving the patient, it has got a clinical angle to it. So whether he is actually doing some calculations or doing some dose adjustment or anything, there is a clinical angle to it. And today we feel that OSCE and OSPE are interchangeable. So there is no requirement to use the term OSPE. OSCE is something that can also be used for phase 1 and phase 2 specialties, because every question has got a clinical angle to it. I thought I'll just address this issue here. Yeah. So what are the various steps in designing a micro OSCE? The first step is to identify which domain you are trying to test. And once that domain is decided, the practical aspect is decided, you have to see in that domain, which is the task that I want to assess. So the task is, for example, counseling a patient. That is a task that has been decided. So in counseling, you could have, communicating about the adverse effects, or communicating about the adherence, or about the OTC. So that task you have to identify, and that task needs to be broken down into subtasks. 1, 2, 3, 4, 5. I'll show an example here. And once the subtask has been mentioned, you give each subtask a score and a time for the entire task. So you have to just create a checklist. And what is very, very important is this has to be a teamwork. It has to be done by 4 to 5 faculty in the department, because defining a task, dividing it into 8 to 10 subtasks, trying to see which subtask is important, which subtask should be given more weightage, more marks. This is something that needs to be discussed, and a consensus has to be arrived before you actually make the checklist. Yeah, one word here about the checklist versus expert rating. Traditionally, OSCE was only about checklist. You have to give marks to each subtask, and the examiner had no say on his thought process as to what he felt the student did. But it is now seen that there is more evidence that an expert rating by an examiner is as reliable as a checklist, and it could even have more construct and concurrent validity. So expert opinion and expert judgment is also very important. So what is now recommended is a balanced approach. So you have a checklist with few points, and you also give a few marks to the examiner so that he can also make his own judgment about the activity. And what we are doing at AIIMS Mangalgiri is we are trying to follow this approach, where you have the proper checklist with marks, and a few marks we are giving to the examiner also as an expert. Yeah. So next about 10 minutes or so, I will just cover the suggested plan based on our experience at AIIMS Mangalgiri, how we are using OSCE in pharmacology. And I just a disclaimer here, we don't come under NMC. So we are not bound by any set of examination aspect. So we are able to modify to some extent. But I suggest that people who have to follow the NMC norms can probably get some idea from what we are doing and probably incorporate it in their own assessment. Yeah, the first thing we have done is we have created a tentative blueprint where we have broadly divided pharmacology into clinical pharmacy, clinical pharmacology, and experimental pharmacology. So these are the 3 areas. And then we divide them into cognitive, psychomotor, and affective domain. So this is the tentative blueprint we have created. And now in each section, we have various competences which we will have. In clinical pharmacy, we have cognitive, psychomotor, and affective. Similarly, in clinical pharmacology, and similarly in experimental pharmacology. So this is the blueprint which you have prepared. I will just see a few examples here. Let's talk about clinical pharmacy here. In clinical pharmacy, as you can see, in the cognitive domain, which is purely a unobserved question station, you could have a dosage form or a drug label with few questions. You could have a station where the student needs to just calculate the drug doses in child or with GFR or with creatinine clearance. You can create a question there. You could have certain pharmacokinetic problems based on half-life, volume of distribution, Henderson-Hasselbalch equation, plasma protein binding. So we are using a few questions like this where the cognitive component of clinical pharmacy is assessed in an unobserved station. While for the psychomotor domain, we have a station where the administration of the drug by various routes, whether it's intravenous, intramuscular, subcutaneous, or ID is used. And the second competency which we are doing is demonstrating the use of MDI or MDI with spacer or rotahaler or whatever, the demonstration, psychomotor domain. While in the affective domain, the student is supposed to communicate about this particular, whether it's how to, if you see the difference between psychomotor and affective domain here, in the psychomotor, the student is explaining to the, demonstrating the use to the examiner, while in the affective domain, he is explaining it to the patient. So the checklist is going to be totally different for the, explaining to the patient component. So we'll see one or two examples here. So this is clinical pharmacy, cognitive domain. You just keep a label here or drug, this thing. You have a few questions. Identify, mention about advantage, what's restrictions. So this is totally question unobserved station. You could have again one question where the patient has come, you given oxytocin, whatever, and the student is supposed to calculate how much of oxytocin has been given. What is important is the key has to be ready, because when you correct, the correction has to be through a key. Or you could have more clinical pharmacy unobserved stations where a person with poisoning has been received at the emergency, and how many tablets of paracetamol he has taken 6 hours earlier. So this calculation also can be given. Of course, there are more examples for clinical pharmacy unobserved station. For psychomotor domain clinical pharmacy, administration of a drug, you have a station here like this where the student is having everything in place, and question can be given to the student, and he's supposed to.
Am I audible, please?
Yes, sir, you are audible.
Yeah. So this is a kind of station, and the student is supposed to administer the drug in that particular format. And what we normally do is when the student comes to the station, there is a lottery: intramuscular, intravenous, subcutaneous, and intradermal. And the student picks up one, and whatever he picks up, the student has to inject that particular route of administration. And we've got different checklists for all this. So the examiner will just mark it based on that. One advantage we have felt is the questions are not leaked out. Even though the student is aware that there is a station of administration of drugs, he does not know whether he will get IV or IM or intradermal or subcutaneous. So he will have to actually be ready with all 4 routes. So this is the OSCE station here. And this is the checklist. I thought I'll just share this thing. If you see here, we have given 10 marks for this demonstration of intravenous route, in which procedures like washing, explain to the procedure to the patient and reassuring, tourniquet, disinfection, inserting the needle, puncture the skin and move slightly into the vein. All these aspects are given. And for 8 marks, and 2 marks we have given for the examiner, where the examiner can also have his own expert judgment and may even ask 1 or 2 questions to the student. This is a little different from the traditional OSCE, where the student does not interact with the examiner at all. But our experience is that it is good to have a little bit of interaction with the examiner. So you have this 8 marks for this checklist and 2 marks for the interaction with the examiner. So this is, like I said, best of both the worlds, which we are using. So this is actually the checklist which we are using. And for the affective domain, so this was for the administration, and the same thing, how to use an MDI or space or whatever. This is again psychomotor domain. The student is explaining to the examiner, and again you have a checklist here: removing the cap, checking dose counter, holding the inhaler upright, breathing out, all this. And if you see here, the weightage is different for different parts. Like for example, starting to breathe in slowly through the mouth and the same time pressing the canister, we have given little more marks for that, even 2 marks. And holding the breath, again 1 mark. So depending upon, while removing the cap is just 0.5 marks. So depending upon the weightage and importance of the particular subtask, marks have to be given, and 2 marks for the interaction with the examiner. So this is a checklist for the psychomotor domain of clinical pharmacy. While for the affective domain, the same thing. The student is explaining it to the patient. So here the communication component is coming up, and you have a checklist where greeting, showing interest in the patient, opening up the discussion. While 4 marks is actually for demonstrating the procedure. 1 mark is for checking the patient's understanding. 1 mark again is for giving more feedback. So if you see here, then examiner's rating based on tone, pace, voice modulation, examiner can also give 2 marks. So 8 marks for this and 2 marks for this. Again, 10 marks. So this is the affective domain of the clinical pharmacy. And now if you see the clinical pharmacology, we have covered clinical pharmacy, just 5 minutes on clinical pharmacology here. You have the, the cognitive domain, writing a prescription. We all are doing. So you have a station where you write a prescription or performing the critical appraisal. This is something which we are doing. I'll just spend 1 minute on that later on. Deep prescribing exercises, clinical problem solving skills, DPL. So this is the cognitive component only, unobserved. Psychomotor, you are given a scenario, clinical scenario, and you set up an IV drip based on number of drops. While affective domain, you are communicating with a patient regarding various actions, adverse effects, contraindications, or communicating with the medical representative. So this is something that can be done. So if you see here, this is something which we are doing. I don't think any other college is actually doing it. We are explaining the importance of deep prescribing to our children, because everywhere we are talking about prescription. So patients land up with polypharmacy. So we are trying to teach how you can deep prescribe. So prescription is given with 9 to 10 drugs. A scenario is given. And based on the scenario, the student will actually write what were the various aspects, what can be done, why this is not good, why that is not bad. And finally, he will say, this was the original prescription, and I have revised my prescription by deep prescribing. Now from 9 drugs, he is just coming to 2 drugs. So you can actually check the understanding of the patient. So this is a deep prescribing exercise which we are doing for the cognitive domain of clinical pharmacology. And then similarly, some certain clinical problem solving skills can be given. You give a scenario and the student is commenting. And same. And for the psychomotor domain, you give a scenario, patient calculates how much ml per minute should be given, and he sets it up in the IV drip. So you have a component where the skill is actually tested here. For the affective domain, clinical pharmacology, you have a couple who you're supposed to, communicate and counsel for oral contraceptive. So again, you have a scenario here. If you see, greeting and showing the patient interest in the patient, opens the discussion, allows the patient to complete the sentence, understands the patient's perspective, offers relevant information. If you see here, 2.5 marks out of 8 are being given for this particular thing, because relevant information has to be given, check for understanding, provide closure, and acknowledge patient and close interview. The important aspect about this is that this checklist can be used for any affective domain. Explaining anything you want to explain, this particular checklist can be given, because it's a little non-specific, because offers relevant information. Could be anything. It could be ADR, it could be contraindication, it could be anything. So we have made this non-specific checklist. Then there is something called linker stations, where you have 2 stations and both the stations are connected to each other. Like, for example, in the first station, you write a correct rational prescription. And in the second station, next station, you say, communicate effectively with the simulated patient regarding the various aspects of the earlier OSCE station. So the student is supposed to write in the first station the prescription, and he has to carry the prescription to the next station and explain the drugs to the patient in the next station. So they are both linked. So this also can be something done and very interesting. In the experimental, just last 5 minutes I'll be taking. In the experimental pharmacology, you have the cognitive domain. You could give charts, graphs, instruments. Psychomotor domain, computer-assisted laboratory, learning, and affective domain about some ethics. One or two examples I'll give. For the cognitive domain, you have a table like this on experimental pharmacology, and parameters and response, what happens to the pupil size, other things. And the student is supposed to identify the class of drugs, write one name, and mention one use and one adverse effect. So this is a typical question unobserved cognitive domain of experimental pharmacology. For psychomotor domain, a computer can be placed with some software, and the student can be given a question saying, demonstrate drug antagonism using anesthetized dog. So he should be able to pick up the correct drugs for drug antagonism, or correct drugs for drug potentiation, or show the various actions of alpha and beta receptors. So these things the student is doing on the computer. Or you could have an effect of meiotics on rabbit eye, mydriatics, or whatever. So these are all psychomotor domain, CAL, which we are doing in our department here. And for experimental pharmacology, affective domain, you could have a station where the student is supposed to communicate about justification whether CAL can be used in place of animal experiments. So here he is communicating regarding the ethics of animal experimentation in learning, and it comes under the affective domain of experimental pharmacology. So after everything is done, after the examination is done, what is very, very important is feedback, because if assessment is the engine that drives student learning, feedback is the oil which can lubricate this engine. So feedback is absolute. In fact, in OSCE, feedback has to be inbuilt. The students are taken around all the stations. After the examination, everybody goes around all the stations and feedback is given to them. What were the common mistakes that were seen and how they can actually improve. So these feedback can be given to the students. So I conclude here by saying that implementation of OSCE in assessment requires planning and teamwork, and designing a station with the task that is possible in a realistic way. So what is important is it should be realistic and feasible. Material needed for each station should be procured beforehand. At least 1 or 2 days in advance, all the stations should be ready. And the score, this is very crucial. The task to be divided into various subtasks and giving marks and weightage. So that is something which needs to be done as a team, and everybody should be sitting together, and depending on the importance, those marks have to be given. And little bit of training and sensitization of the examiners need to be done, because somebody who has not done OSCE first time, he may need a little bit of sensitization. So that is not very difficult. That can be done. If you have a simulated patient, like in our case for affective domain, we make our housekeeping staff sit or somebody sit, you have to have a little bit of training to them, so that if 1 or 2 things you want them to say, they will be able to say as a simulated patient. Test run at least 1 day or 2 days before is very important. And before the OSCE examination, it's important to brief students regarding the entire process. So if this is done, I think we can and we must use OSCE to some extent, at least in pharmacology assessment. So from my side, I've completed. Thank you very much, and I'll be happy to answer any questions.
Thank you, sir, for your wonderful talk. I think the content selection, organization, delivery, everything was addressing the today's objectives of today's session. You have unfolded many complex concepts actually that helped us to develop a concept framework, and probably that framework will help us to implement micro OSCE at our institution. So thank you once again. Some of the key takeaways of your session was how micro OSCE is different from the traditional OSCE, and also you have justified the rationale of using micro OSCE. Apart from this, you also said what kind of contents to be assessed by OSCE, what are the various types of stations that to be used to assess skills pertaining to various domains. So those really connect the dots of our query. So once now, I think this session is open for question and answers. I can see some questions popping up in the chat box. So we'll take the questions in the chat box first, and then we'll take the voice questions. So sir, speaker sir, if you allow me, now I can open my chat box and I can read those questions aloud in verbatim. Shall I go ahead, sir?
Yes, sir. Yes, sir. Yeah. I'll be grateful, sir.
Well, I can see only one question in the chat box, and it says, sir, the communication skill is psychomotor domain. Also, not of it is affective domain. Sir, do you want me to repeat the question?
Somehow I got disconnected. The voice.
Okay,
Please,
okay,
please,
okay,
sir.
okay. The gentleman is asking, the communication skill is psychomotor domain also, not all of it from affective domain.
Yeah, basically, when we talk about communication skills, generally we say that it is effective, but that point is well taken. None of the skills is actually 100% cognitive or 100% psychomotor or 100% effective.
Absolutely.
We only talk about the predominant domain. So in communication skill, I feel the predominant domain is the effective domain. There could be some psychomotor angle that is also there.
Yeah, that really makes sense. And now I think this is the time for voice questions. Now, participants, you can unmute yourself and speak out one at a time, please.
Yeah, but we would be happy to have any clarifications or queries, please.
Okay. Yes, sir. Please go ahead. Sir, meanwhile, there is one more question just now popped up in the chat box. How can we assess empathy while students communicate regarding the drug use? Does it come under affective domain?
Yes, absolutely. Empathy comes under affective domain. Empathy is nothing but putting yourself into the shoes of the patient. So what we can do is, suppose if the patient has come to you with an adverse effect of a drug, for example, and you are supposed to communicate to the patient as to why this adverse effect has happened and what is the way forward. So maybe the students' empathy skills may be checked here. So you could have a station where we can say that a patient has come to you and he has had an adverse effect with this drug. Now please communicate with empathy regarding and giving information as to the student and the patient as to why this happened and what is the way forward. So that kind of a station can be created for empathy.
Yeah, the next question, ethical aspects comes under which domain?
Ethical aspects, actually what they are affective domain, but in what we are doing is we are putting it under the experimental pharmacology, because the ethics of experimenting or on animals, just to show that this drug is causing meiosis. Are you justified to put this into a rabbit's eye when you know that the drug is going to cause meiosis? Here we are putting it in effective domain of experimental pharmacology.
Next question, how question can be framed? So this is what you have elaborated a while ago, but if you could summarize this.
What kind of questions?
How questions can be framed? Yeah.
On ethical on empathy, ethical aspects. Okay.
Not really. It is unrelated to any specific things. The question itself is written, how question can be framed. Probably it is related to, let me check. Yes, the same participants.
Ethical aspect. Yeah. So for example, if you are talking about the ethics of animal experimentation, so what happens is you could probably say that can you justify, you could create a question saying justify using CAL in UG education where the drugs effect is already known. So you can have something like that so that the student can actually give his comments. But what I feel is, for this, a debate is something which will be very, very useful. And what we are doing is we could have a debate on the ethics of something, this and this. So that can also be done, sir.
Yeah. Dr. Nishi Ganda if you can unmute yourself and tell us what exactly it means, the question that you have asked. I'm unable to interpret it. How do we ask as many skills from second year students?
Students. Okay, maybe she wanted to ask, can we ask all these things in second year students? So this is just a blueprint of it. You may not use everything in your examination. So what we are doing is we are just keeping 4 stations in our micro OSCE. So we have the traditional examination and what is happening, and we're just keeping 4 skills. So my suggestion is any of these 4 skills can be used as part of OSCE. You don't have to use everything in this.
Yeah, and the next question actually.
Sir, we can continue the question in the WhatsApp chat also. And I feel.
So do you want me to wrap up, Dr. Kamat?
Yeah, sir, we can switch over to the next speaker.
Okay.
Yeah.
Okay.
Because time is also
We are running out of time.
limited. Yes.
Yeah.
Thank you, sir. Thank you very much.
Thank you.
So the second speaker is the Dr. Pinaki Chakravarty, and I would like to invite the moderator for today's session, Dr. Sandhya Kamat, to kindly introduce the speakers. Dr. Sandhya Kamat.
Good afternoon, everyone. It's evening, so good afternoon, good evening, everyone. At the outset, I would like to thank you, Dr. Kamal, for your kind introduction at the beginning of the session. I would also like to thank the organizers for inviting me as a moderator for this session. The next session is from marks to grade during assessment in pharmacology practical examination, and it appears to be a interesting topic, and Dr. Sharma in the beginning told us assessment has to be valid, reliable, and how it's important to use the best assessment. So I'm really looking forward to Dr. Pinaki Chakravarty's topic and seeing how he can tell us how we can go from marks to grade for assessment in pharmacology. And maybe in the next few years, we could change over from marking system to this grading system. And so without much ado, I'd like to introduce Dr. Pinaki Chakravarty. He's currently the professor and head of the Department of Pharmacology, Tejpur Medical College, Tejpur, Assam. He has been an assessor at the National Medical Commission in New Delhi. He's also a member of the Pharmacovigilance Program of India. He's a CCSA nominee, and he's a member of the Medical Education Unit. He's also a member of Institutional Ethics Committee, and he has been a writer and an examiner. So welcome, Dr. Pinaki, and I request you to kindly go ahead with your session.
Thank you, Dr. Sandhya Kamat, and thank you, organizers, for giving me this opportunity to talk on the topic of from marks to grades during assessment in pharmacology practical examinations. Actually, Dr. Sushil Sharma has made my job really easier. And actually, I did my MBA, and out of all the many things that I have learned, one thing which actually is very important, that you need not reinvent the wheel every time. So all the stations and all the checklists, actually we can use what Dr. Sushil Sharma has actually prepared for his institute, and we can customize according to our own needs. So I would like to share my screen. I hope I am visible. So, am I visible and audible?
Yes, sir.
Kamal,
Yes, sir. You are
Okay.
audible and visible both.
Okay, so very good evening to all the participants, and I'll actually be very short because I have allowed Dr. Sushil Sharma to take some of my minutes and I am happy that he has done justice. And from marks to grades during assessment in pharmacology practical examination. So I'll start. And assessment is important because we need to maintain quality of our product. So becoming a medical profession is a noble and rewarding journey that demands dedication, perseverance, and a commitment to lifelong learning. In our country, where the healthcare system plays a crucial role in the lives of millions, medical students hold a significant responsibility. Aspiring doctors must not only excel academically, but also embrace a set of values and practices that align with the country's healthcare ethos. Assessment encourages students to work more harder, and it actually serves to understand their level of attainment. Ranking of the students is one thing that we always actually look for, who are brighter, and also we focus on who are weaker. And then, as Dr. Sushil Sharma has already said, feedback, whether it is a formative assessment or say even in OSCE. So feedback to the students and also to the teachers. So outcome of the student, outcome of all the assessments actually is to see that what was the effort from the student's part, and as a teacher, how was our quality of teaching. And design of assessment, already we have talked, and we need to implement the different assessment procedures. Please understand that CBME curriculum is still new to us, and we need to refine these techniques over a period of time. So evaluation is a process in which the analysis of the result obtained from measurement of a trait of an object, person, or activity is done on the basis of certain social, cultural, or scientific standards, and the relative position of the object, person, or activity is determined as relative to the trait. So when we evaluate, we normally actually give marks to the students. The term marks conflates the concept of scores, that is a raw test performance, and the grades is the level of performance. Neither scores nor grades represent interval scales, and therefore, properly speaking, arithmetic means should not be calculated during aggregation. The difference between marks and grades. So marks is a traditional system, grade comparatively new system for us. Marks, they are denoted by numbers, and these are normally denoted by letters. There's a precise marking in figures, and here we have a range which is not very clear-cut, but a vague range. Marks in numbers or percentage, and here we have A plus A, or for outstanding we give O. In marks, what happens? Students, they aim at getting good scores in each subject, and there is a spirit of competitiveness and encourage the student to outperform each other. But in grades, it ensures a kind of overall development, and there is no such competitive spirit, and the motivation is little less. In mark system, what happens? The pressure of the students, it increases. There is only the academic aspect, and passion to outperform make students ready to take pressure in higher classes. But in grades, the pressure is little less. We assess both academic and non-academic, and it has been seen that they may not, cope in higher classes. So this is the table when we give marks and when we add, and then there are ranges. So from 91 to 100, it's outstanding. So grade point is 10. From 81 to 90, it is excellent. A plus, grade point is 9. 71 to 80, it is very good. A, 8. 61 to 70, good. B plus 7. 51 to 60 is above average. B, 6. 41 to 50 is average. C, 5. So as you know that now 40 is the pass mark, and below 40 is fail, and If it is absent, then the grade point is 0. So here, the marks obtained by the student divided by total marks into 100 will give us the percentage. And in many places, or especially in university level, non-medical, I have seen they use this cumulative grade point average, and they can convert it into marks in percentage by multiplying with 9.5. And in many places, credit points are being allotted, and they can actually transfer the credit points in their grading. So new things and new concepts are coming. So I'll not take much time. So recommendations are: scores should always be converted to grades before aggregation. The process of converting scores to grades requires both subjective and specific skills and familiarity with the educational principles. Whatever grade scale is used, it should be readily distinguishable from scores. The median should be calculated as the measure of overall performance, not the arithmetic mean. Recommendations: the interquartile range should be calculated as the measure of dispersion. Students should be informed of both their score and grade for each assessment, and where possible, assessment should report performance by individual assessment and not by a single aggregated mark. And when aggregation takes place, it should be possible to aggregate students' performance by type of assessment as well as by academic subject. And students who perform inconsistently should receive particular scrutiny during assessment. So to wind up, becoming a successful medical professional in India goes beyond academic achievements, and it requires a deep-rooted commitment to cultural sensitivity, ethical practice, holistic care, technological integration, and continuous learning. So what I always say to my students, that you don't study to pass the test, you study to prepare for the day when you are the only thing between a patient and the grave. It's not my own saying. Margaret has said long time back. So with this, I wind up, and thank you, everyone. Thank you.
Thank you, Dr. Pinaki, for the presentation on marks to grades during assessment in pharmacology practicals. It was an interesting topic because I think we don't have the grading system, so slightly difficult topic as to how to take this further. Can we go on to the question? There were 2 questions in the chat box, so can I go on to that? So one of them have asked Dr. Manjunath. He has said he's sorry for his analogy, but grades versus marks looks like hooking onto smoking, as it is better than oral tobacco. It will ultimately acquire the same nature of measuring the student's performance. So I think what he wants to say is that finally the measuring the student's performance is the same, and I think he would like you to elaborate a little more on this, the difference between grades and marks.
You want me to answer this?
Yes, yes.
Okay. Yeah. So basically, as of today, what I understand that all of us are following marking system, and in most of the medical colleges, when I go as an examiner or someone who comes to Northeast, so we are all conversant with the marks. And it is my personal observation that in pharmacology practical, very rarely students, they fail in practical part of it. And nowadays we have the central assessment where the theory papers are being evaluated in the university. And of course, there are students who cannot, all the students cannot pass. But marks, as of today, I think even NMC also are advocating marks only. And what is the advantage of having grades is, I told that basically, the weaker, it's something like, if my daughter achieves, say 95% and someone's is 91%, both are basically outstanding. Now, if someone asks how is your daughter's result, I would like to say that it is 95% or 91%. So we usually don't talk in terms of grades as of today. But you may argue that marks are better. Someone may say grades are better. It's all about individual. But I have seen examiners. There are also two types of examiners I have seen. There are many who are very lenient and who are actually, very much student friendly type. And there are other few who are very, what should I say? They're not very lenient, and So it's all and with experience, actually, you learn how to assess, and basically every student for me is a learning experience, and the weaker students, basically we need to focus more on them. So I think that's all personal.
Thank you, Dr. Chakravarty. There's another question by Dr. I think Sanjib Das. He said, how do you take care of inter-assessor bias, lack of precision, and expanding scope of feedback? How do you take care of inter-assessor bias, lack of precision, and expanding scope of feedback?
Yeah, that point was actually, it is very common. And that is addressed by Dr. Sushil Sharma. And he said that sensitization and little bit of, say blueprinting, and all the examiners should be aware of all the checklists. And even then, I would not say that there would not be any inter-examiner bias, but it can be minimized by discussing things beforehand. And we actually have a checklist, and I feel that this checklist should be common to all the institutes so that it becomes easier and familiar for everyone when examinations are there and externals are coming from different places of the country. And but even then, little bit of sensitization awareness has to be there.
There's another question, sir. In case of grading, I think you addressed this, but since it has been asked, I'll read it out. In case of grading, how pass or fail can be decided? In case of
grading, basically, see, if 40 is the pass mark, and if if it is 40 and above, then it is passing, and 40 is, I think it was C, I think. So below C, it is F, fail. So it is actually passing and failing. Now NMC, they have recently said that 40 and then aggregate 50% like that. So we all know what is the pass mark. So even if it is in the grading, O is the outstanding, the higher most, and I think C is the last where you make the student, say pass.
Dr. Kamat, do I have time for additional questions?
Yeah, we can have one more question.
Okay. So there is one by Dr. Chitra Khanvelkar. Grading should be for practical or theory also?
Very tricky question. Yes. See, now in actually postgraduate level, there are universities who are giving grades. Even when I appeared in my MD, I got in grades. And in theory also, the formula is same. Basically, you have to give marks and then you have to convert into grades. So you can implement in theory also. But as of today, what I understand, most of the universities, they are giving marks in the result sheet. It comes as marks, and it can be converted to grades, and in theory and practical both. Thank you so much. Thank you. Thank you.
So there's just one more question by Dr. Sanjib Das. So I'll just take this. Is it a valid system deciding ranking or merit list? He's asking you the question. Is it a valid system deciding the ranking or merit list? So can you elaborate, Dr. Das?
No, I didn't get his question actually.
Yes, sir. Actually, if we use grading system in ranking exams where we make ranks, right, merit list, So I don't think it is a valid system because always we take a range. For an example, 80 to 85% that is translated to grade B. For an example, 93.
You're absolutely correct, sir. For grading, I mean, for ranking, no, you have to have marks because if I get 99, and if someone is getting 99.5, say, he will be above me. So grading is not possible for ranking.
Yes, that was my query actually.
Yeah. Thank you, everyone. I think we are running short of time now.
Thank you so much, Chakravarty. I think your questions, your answers to the questions were answered beautifully, and I'm sure it helped everyone to understand the topic much better. Thank you so much.
Thank you.
So we are coming now to conclude this session. I feel both the sessions have been beautifully covered by both the speakers. I just would like to extend my sincere gratitude from the National Association of Pharmacology and Therapeutics to both the speakers, Dr. Pinaki Chakravarty and Dr. Sushil Sharma, and both the moderators, Dr. Sandhya Kamat Madam and Dr. Sanjib Das. They have beautifully moderated both the sessions. And participation in today's both the sessions were very enthusiastic. We are eagerly waiting to meet you all next Thursday at 3 o'clock. Thank you all. With these words, we are concluding this session. I just would like to extend my sincere gratitude to all the participants for joining us at National Association of Pharmacology and Therapeutics. Thank you all.
Thank you so much. Thank you.